In a moment. We have committee members in the Civic Centre with officer support. The meeting is being live streamed via YouTube and will be available on the Council's website. Some housekeeping for those in the Civic Centre. There are no fire drills planned, and if the alarm goes off, please leave by the emergency exits and congregate on the rear car park. Please turn mobile phones off and switch your microphones off when not speaking. For those joining us via Microsoft Teams, please remain muted and indicate at the appropriate time when you would like to speak, and I'll bring you in. I'd like to welcome Councillors Hindle Taylor, Howarth and Peat to their first meeting of the committee. Thank you very much for joining us. We are really grateful to our guests for attending this special meeting, which I'll mention more in a moment. Please can I ask each member of the committee to introduce themselves, followed by officers.
Good evening. My name is Councillor Leslie Pritchard. I'm the Vice Chair of this committee. I'm a ward member for Lostock Hall.
Councillor Nikki Peat, St Ambrose Ward in Leyland. Councillor Hindle Taylor, Councillor for St Ambrose Ward as well, so I couldn't get my words out one.
Councillor David Howarth, member for Howick and Priory in Penwitham.
Councillor Lou Jackson. I'm elected member for Earnshaw Bridge here in Leyland.
Good evening, Michael Green, Councillor for the Moss Side and Midshore area and the substitute member of this committee this evening.
I'm Matthew Pavlish and I'm the Democratic and Member Services Officer.
Hello, I'm Darren Cranshaw, Head of Democratic Services.
Thank you, everybody. I'd just like to add I'm the ward member for Walton-le-Dale West. Item 1, apologies for absence. We've got apologies from Councillor Joan Burrows, and we're very happy to have Councillor Michael Green substituting this evening. Item 2, declarations of interest. Do any members have any interest to declare? Councillor Jackson.
I'd just like to declare that I'm a hospital governor at Lancashire Teaching Hospitals.
Thank you, Councillor Jackson. Sorry, Councillor Howarth.
Member of Lancashire County Council who have responsibility for social care.
Thank you, Councillor Howarth. Item 3, minutes of the meeting held on Wednesday the 18th of March 2026. Members are asked to approve the minutes of the last meeting, so I can sign them as chair. Everybody happy to approve? Thank you very much. Item 4, recommendations update. Members are asked to note the responses to previous recommendations and agree to remove items marked as complete. Is everybody happy to do that? Thank you. Now we move on to item 5, hospital care and patient experience. Today we are joined by Professor Sarah Morrison from Lancashire Teaching Hospitals, Steve Walmsley from Health Watch Lancashire and Emmy Walmsley from Health Watch Lancashire. So what we'll do today, instead of having 2 separate questioning sessions, we'll do it all as one panel so that you can both input into the questions that we ask. Please could you give us a brief introduction into what your organisation does, please? Is that okay? Starting with Professor Sarah Morrison, please. Thank you.
Do I just press it once? Is that right? Okay. Good afternoon. My name is Sarah Morrison. I'm the Chief Nursing Officer at Lancashire Teaching Hospitals, which is a district general hospital and also a specialist tertiary hospital, providing a mixture of acute and community care services for the population of central Lancashire and also the wider Lancashire and South Cumbria ICS.
Good evening, my name is Steve Walmsley. I'm the Operations Manager for Health Watch across Lancashire and Cumbria. I'm joined by Emmy Walmsley, who is our Senior Engagement Officer for Lancashire. Healthwatch Lancashire is an independent organisation that champions the views of people using health and social care services across the Lancashire area. We're part of a wider network of 153 Healthwatch across England, and we have some statutory powers to sort of act and observe to support services improve. We do this through a range of project work and through general engagement activities. Thank you.
Brilliant, thank you very much. We'll now move on to general questions. Starting with question 1. What are the key issues and priorities for the NHS and Hospital Trust?
So for Lancashire Teaching Hospitals, currently we've got a number of priorities that are outlined in our newly published trust strategy. These include ensuring that we've got an estate that is fit for purpose. Members may be aware that we are part of the new hospital programme, albeit not in the first wave, and that causes us some considerable challenges with a significant amount of backlog maintenance within the organisation. It means that the care we provide is provided in estates that are much smaller than modern service specifications, and that impacts on the ability to provide spacious areas for rest and care for both families and for the patients themselves. Addition to that is the ageing nature of our population and the challenges in providing care in an equitable and suitable way closer to home for people. As a result of those challenges, which are shared right across the system, our elderly people do spend longer in the emergency department than any other groups and suffer their detriment thereafter by deconditioning whilst they're in hospital and not being able to get out back to their families and in their care. This is a key priority for us because we believe that this is affecting not only us as secondary care but families and the choice to be able to stay at home, but also it places extra burden on social care and voluntary sector services. We are really focused on making sure that we are understanding our populations more robustly now by using a health equity lens. We know that more deprived communities have poorer outcomes right across the board, and we've started to do some work to develop and mature our approach to changing the way we deal with different parts of the community to make sure that we try to bridge the gap so that healthy life expectancy is more consistent and there is less of a gap. That has to be done in partnership with public health and across other healthcare providers across the system. And our intelligence to do that is quite juvenile at the moment, and so we are focused on trying to understand how we do that in a really practical way when we're looking at things like waiting lists or cancelled operations or appointments, because we know that there really is a link between that. There's a particular link between deprived areas and the use of the emergency department as a first port of call for care, and we know that we could both improve the experience of the wider population by making the A&E department less congested, but also improve the outcomes for those people that perhaps aren't using primary care or other services in the way that might serve them more effectively. A couple of other points. It wouldn't be a meeting without discussing finance, and I think it's fair to say that the financial position of the organisation is very challenged. We are in oversight at the moment from NHS England and have some special powers that are in place around what we are permitted to do financially. This is forcing us to reorganise and restructure the organisation, but also the way we deliver care so that we've got an affordable health system. That does come with challenges and our staff are absolutely critical to making sure that we transform those services whilst keeping them engaged, feeling like they're delivering really great care. Finally, from a performance point of view, we know that our waiting list times have been longer than we would want them to be, and we've struggled to recover from the pandemic as quickly as some other areas. In part, that's because we're a specialist provider and because we've got just larger waiting lists by the nature of more people from the whole of Lancashire and South Cumbria coming to the hospital. But also it's some of those challenges that I've just described that also limit the ability to simply put on additional activity to help catch up. However, we're making really good progress around that, and that remains a key priority for us this year, underpinned by our Always Safety First strategy. And that strategy really is the golden thread through all of that work about making sure that we are reducing adverse incidents in hospital and really focusing on being a partner in care with families and patients.
Thank you very much for that. Can I bring in Councillor Michael Green?
And set out that improvement was required across all criteria, with the exception of the caring element, which was actually rated as good. What steps has Lancashire Teaching Hospitals actually taken to improve on those previous ratings?
So it's a widespread programme. Those ratings do include consideration of the management of money and performance. And performance is particularly related to waiting lists, cancer and the diagnostic standards. And so that work that I've just described there about making sure that we're making absolute most productive use of the resources that we've got in the hospital, things like theatre productivity, making sure that we've not got any spaces left empty in theatres or outpatients has been a big area of focus for us, as have making sure that the right patients are on the right lists to see the right people. We know there is some waste where patients can get moved from one specialty to another, and so we've been working really hard to try to make sure that that area of planned care improves. The second area of urgent care really has become one of the key priorities for the Trust, and you will see in the board assurance papers that come to our board of directors, the Chief Executive has set out the strategies that are needed to address the urgent care problems. I'm the executive lead for frailty, for example, and a frailty nurse by background. The Chief Medical Officer is focusing on the way in which the doctors assess and process and diagnose patients. And then we have other members of the team that are dealing with other parts of the urgent care system. So we understand that by addressing the root cause, and that is that we've got an over-occupied hospital with resources that don't currently fund the amount of offers that we have, means that we're more likely to have a right-sized hospital that will deliver better care to people. In addition to that, we've had a strong focus on governance and making sure that the people who are leading the organisation have the skills and capability to do that effectively.
Thank you. And can I ask you when is the next inspection due, and what rating do you expect to receive?
So we're expecting a well-led inspection this year. The CQC have just changed their methodology, and so we are just trying to get up to speed with exactly what that will mean. Typically, we would have what's called a comprehensive inspection, and then we'd have a well-led inspection, and one would inform the other. We're not yet aware of what the configuration of that would be. We would expect to be good from a well-led and caring and safe perspective in all areas, probably with the exception of the emergency department. And I say that because we understand that while patients are waiting the length of time they're waiting in the emergency department and we have corridor care, that would not be assessed as being good in the safe domain. We would be requires improvement around responsiveness because that's the area that deals with performance, cancelled operations, outpatient appointments, things like that. We are on a journey though, and it does take time to recover from the pandemic and also to get back to a place of where we were before the pandemic. I do believe we are making good steps and anticipate within the next 2 years we should be in a CQC good position.
Can I bring in Councillor Jackson, please?
Hello, and thank you very much for coming this evening, on this warm evening, to come and talk to us and answer our questions. But my question is about the process of managing beds. Could you tell us a little bit more about that, please?
Certainly. We have a operational team that have oversight of all the beds available in the hospital, who liaise very closely with the emergency department and other areas where GP patients come in. There are probably around about 10 to 12 ways in which to enter the hospital, ranging from the assessment units through the emergency department, through outpatients, through radiotherapy. There are opportunities at lots of levels for a patient to be assessed as being unwell enough to require admission to hospital. So that takes some doing, and the teams have to very carefully prioritise who is the patient that is in the most need, that needs the bed that becomes available. We have a discharge team and general operations team that focus on the tasks that need to be done in order to make sure someone's length of stay is absolutely optimum for them. It doesn't mean rushing people through, but it does mean that the delays of a day where you might wait for a scan, for example, we try to focus on reducing those so that the length of stay overall is reduced. We have discharge facilitators on the wards that work with the ward team to make sure that from the minute the patient arrives, discharge planning is commenced. And then those trust operational officers work with ED to identify the bed, and then the specialty that accepts the patient would then give the signal that that patient is okay to be transferred up to that ward.
Healthwatch Lancashire are currently looking at the discharge process pathways in terms of the experience, and an offer from us is, we're happy to help support looking at the effectiveness of that. It's very early in the stages of planning at the moment. One of the things that we have liaised with the trust is that, we are wanting to look at that experience, particularly how people get from hospital to home, to make sure it's as right as possible, and that's based on feedback that we've received from previous pieces of work. So, we make that offer.
Thank you.
Gladly.
We'd accept that, thank you.
That's good to hear. Can I bring in Councillor Hindle-Taylor, please?
How do you respond to patients' concerns, and how is this feedback used?
So we have a few mechanisms to do that. We try, wherever possible, to resolve any issues locally. It's much better for the patient if they can speak to the person that's looking after them, or that shift leader, to say, I'm worried about this, can you help me? And we would expect staff to be able to respond in a way that is suitable and acknowledges and listens carefully to the concerns raised. That isn't always the case, and sometimes patients feel, or families feel, vulnerable raising concerns in an area where they might be being cared for. And so we offer a patient advice and liaison service, or a PALS service, which is a number that is the same for every patient across the organisation. They can ring that number and raise a concern, and that PALS service then act as an intermediary. So they'll then facilitate somebody resolving that concern. Sometimes that is successful, often it is. But sometimes it can be really challenging to resolve the concern, and then there might be a requirement to write a formal complaint. That happens in less than 1% of people that use our services. That it's very infrequent when you look at the context overall, but when you consider the emotional effort and energy that people have to deploy to complain, and the further harm really that causes them morally, we do try to do everything we can to avoid people needing to do that. And sometimes that means being really transparent that we've made a mistake and got something wrong, and we place a great deal of importance on candour and being honest when that does happen. If you were sick and you were on a ward, or you were visiting somebody and you were worried about their condition, we also have something called call for concern. that is a phone number. It's on the posters as you walk around the hospital. You can call that number and say, for example, my mum is in ward 3. I have concerns that she's deteriorating and I'm not being listened to. And that then is an independent team that can come in, have a look at your loved one and then determine, do they need some additional medical reviews, or is there something else that is going on around the care?
Right, I didn't know that.
Councillor Green?
Thanks, Chairman. If I could just ask a follow-up to that. So when patients wish to raise concerns, can that be done in an anonymous way? Because obviously you are dealing with very vulnerable people, and certainly elderly people, etc., have said to me in the past, well, such a thing isn't happening, right, but I don't want to make a complaint because I'm sitting in this bed and I'm reliant upon the staff to look after me. So they feel that they can't make a complaint because they might be treated badly in some way. How do we get over that? Can it be dealt with anonymously? And are the figures in terms of complaints realistic, or is it low because of issues such as this where people don't wish to raise issues?
Yes, I think it is lower than probably the overall experience of people. There is an opportunity to raise something anonymously. However, I'm not sure that is well advertised, and so actually I think that is something that I could take away with me to say, let's make that more readily known. I would absolutely agree with you that when you're in a vulnerable state, making a complaint about your care is very difficult. However, the call for concern does give that ability to do that. If you were worried about your health at that time, and I want to say that because I need people to know that they can do it, there certainly would not be any intentional repercussions. I do understand why people feel like that. But we do have instances where staff might feel that they need to raise a concern about something, and we have something called freedom to speak up arrangements where we have guardians and champions across the organisation that then facilitate that for staff. So I'll take an action to have a look at how we publicise the anonymity associated with PALS, so that might encourage people to do that. Thank you.
Just to add on to that, Councillor Green, one of the blessings that we have in our role as Health Watchers as an independent body, people come to us expressing their concerns, and one of the things that we do advise people to do is to give those reassurances to members of the public that the complaint is a process. It's not necessarily a mechanism to get someone in trouble, for want of a better expression. As part of our sort of situation, Emmy sits on the patient experience group and various other forums with the trust as well. So we do feed in soft intelligence to the trust about some of the concerns that people do raise, and it is very, very well received, and it's always acted on. We always get quite strong reassurances from the patient experience team that, you know, what has been forwarded to the trust has been acted on in some way, and we're very lucky that we have that partnership. Adding into that, you know, the other avenues that we have to sort of help support and inform trusts of its situations anonymously is we collect feedback and we publish it on a quarterly basis about the themes in the area. So it does give trusts that sort of heads up, if you will, for issues that are ongoing. And some trusts have approached us when they've seen our reports say, you've mentioned there's a lot of X in an area. Can we just ask you about that, and we'll have a conversation? So that is an anonymous way. In terms of tracking the numbers, it is a public document and it is out there. But in terms, I couldn't be able to give you any specifics for Lancashire Teaching Hospitals because it's pan Lancashire. But just to give you that reassurance that there are other ways of raising issues. Thank you.
Thank you. The next few questions are for Health Watch. Can I bring in Councillor Pritchard?
Thank you for that feedback about the trust. That was really helpful. Could you give an overall assessment of the trust and how you feel that they're managing?
That's a question I can't fully answer because as our role as an independent body, we don't take any sort of partiality to any one service. We must remain independent as part of our mandate. In terms of sort of the links that we have with the trust, I would say they are very strong and they are very responsive to any concerns or queries that we raise. You know, the patient experience team have really good links with yourself, don't they? I couldn't give an assessment of the trust, if I'm honest, other than to say that, you know, they are very receptive of what we do. We do hear examples of stories of people using A&E and corridor care. Like I said, that is regularly fed back to the trust, and we always get a response and some reassurance on the issues. Thank you.
Were you involved in the Care Quality Commission's inspection of Lancashire teaching hospitals?
So Healthwatch sits as like a committee of the Care Quality Commission, so they do approach us with the request for information around different service providers. I'm not aware of them approaching us recently about Lancashire teaching hospitals because I've only been in the managerial post for the last 6 months. But what sort of does happen is the CQC do contact us to say, have you heard anything about this particular issue? But we haven't had anything about Lancashire teaching. Generally, they do only approach us about social care settings at this moment in time. We're still sort of reaffirming that relationship with them. Thank you.
Thank you. Councillor Jackson.
I think I might pass over this next question because Professor Morrison, it's to do with inspections, and I think you covered it quite well there in your last answer, talking about the connection between Healthwatch and inspections in the hospitals. I think you answered that to the best of your abilities, so I'll pass over that next question, Chair.
Thank you, Councillor Jackson. Can I bring in Councillor Pritchard, please?
Thank you, Chair. The feedback that you receive from patients, what would that tell you about how safe and effective their care is from Lancashire teaching hospitals? Thank you.
The feedback that we receive about the hospital trust in particular generally concerns issues relating to accident and emergency or issues related to communications primarily. It's generally feedback on letters and phone calls that people have received. We've had pieces of work in the past where we've heard from members of the deaf community about issues where booking an interpreter for appointments has been a problem. Now the trust actively joined in a task and finish group that we set up last year to sort of address those concerns, and I'm very pleased to say that there have been several developments on the back of that which we will be publishing soon on our website. But to give a short summary, everything that we asked the trust to do, they've done. It was firming up the processes of making sure that interpreters were booked and things and other steps like that. In terms of the other part of the question where we're looking at sort of general feedback, I would say the feedback is echoed across all trusts in the county, and that people are averse to going to accident emergency departments because of over demand. People sometimes don't quite know how to approach the complaints process, which is why we signpost to places like PALS and charities like Advocacy Focus to help give people that step up, because it is, like Professor Morrison said, it is quite emotionally challenging to raise issues. One of the things that we continue to do is sort of support the trust in the journey of helping make communication simpler. Other than that, you know, corridor care has been something we have heard quite a bit about recently, given the recent winter pressures and issues such as that. But as I said earlier, you know, we've raised these with trust and we've had responses to. I think it's a situation that's sort of across the country, whatever trust you go to, that there is sort of that over demand and over, I don't want to use the word over reliance, but there's a lot of pressure on trusts.
Thank you. Thank you. That's really encouraging to hear that you've worked with the trust to look at issues around access for the deaf community. Just wondering, in terms of other communities, so dementia patients, for example, is the same consideration given towards other groups?
It depends on the situation. Our general engagement does involve us going to a lot of groups where people are living with dementia. So there's ones in Penwitham where we do get a lot of sort of engagement from the public because we built up that trust with those particular groups of people. We recently did a piece of work looking at the ageing population across the county and some of the more social care based challenges that people are experiencing in relation to choosing to go into residential homes or living in their own home. A resounding everybody wanted to stay in their own home. But in terms of sort of liaising with the trust and the issues of that, it does depend on what we get back from the engagement. So Emmy goes to quite a lot of engagements around the area. You can't always predict what you're going to hear from those engagements, but if off the top of my head we've not had any sort of particular groups experiencing challenges or barriers to accessing the service other than members of the deaf community in the last sort of 2-year period. One of the sort of blessings of partnership that comes from working with the trust is, you know, they're active on the VI forum, we're active on the VI forum, visual impairment forum. So from that perspective, there's a lot of pieces of work going on that try to address those plates that are spinning all the time, for want of a better metaphor. Thank you.
Thank you. Councillor Hindle-Taylor.
How does Lancashire Teaching Hospitals respond to patients' concerns, and how is this feedback used?
So each concern or complaint is reviewed by the team that have been providing care for that patient alongside an independent person. The points of each of the areas of concern are reviewed against the medical records, and consideration is given to the feedback with factual responses provided in quite some detail. Complaints responses can range from 1 page to 25 pages long if that many concerns are raised and people want to know certain details that perhaps they've left hospital not knowing or are unclear about. The complaint letters are all read by myself and John Howells, the head of patient experience, and we sign those off so that I have a very clear view of what that experience is like in reality for people. And that is very helpful for me because I can then triangulate what people are saying that we're going to do against what I am seeing in practice, and I can make sure that there is that golden thread, which I often do. There are occasions where repeated issues come about, and then they might be registered on the risk register, and then they'll form part of an improvement programme of work in future years. So a good example of something like that would be where families have not felt as involved as they might like to be, and they felt communication has not been clear or has been confusing. We launched something called John's campaign within the organisation before the pandemic. In the pandemic, we did some further work on that to make sure that carers felt welcomed in the organisation. We do know that that isn't always the case, and we do have to really pay attention to that. And then we're just revisiting that work again now to make sure that that connectivity between the patient and their family is really strong, because we know if the family members are having a bad time, the patient will be, and vice versa. And so we try to look at the patient as a whole with their loved one. There are occasions where a follow-up meeting might be required, or access to information. People sometimes want to see all of their records, and they can make an information request to see that. Or alternatively, they might just want to talk about their experience and debrief from what's been quite a traumatic experience if they've been critically ill, and they might have forgotten certain aspects of their journey, or they might have felt some parts were really good, some were not. We use that, we take it really seriously, build it into our patient improvement plan for the year, and focus on the things that matter to patients, and use the staff survey to the patient survey to triangulate. So at the moment we're looking at discharge, As my colleague has just said, we're looking at the quality of food and the information provided on ward rounds, and they seem to be the themes that are coming through that really make a difference to patients.
Agenda item 5B, patient experience in A&E, and these questions are aimed at Lancashire Teaching Hospital. Can I bring in Councillor Howarth, please?
Yeah, what's the average time it takes from an ambulance arriving at A&E to the patient being successfully handed to hospital staff?
So there is a target that means that we should be completing hospital handovers within 30 minutes. We achieved that for around about 60 to 80% of patients, depending upon the day of the week. We have escalation processes in place where that can't happen, and ambulances are sometimes queuing outside the emergency department, where we have a series of internal changes that we make in order to move patients further up the chain. It is an area of focus for us. We know that staying in an ambulance longer or on a corridor waiting to be handed over isn't a positive experience and does impact the community. So it is a really important area for us.
Councillor Jackson, please.
It's a simple question, really. It's about wait times. What's the current situation as regard waiting times? Are we down from last year? Are we up? Is it levelling out? I know there's always circumstances that will come into play that are extraordinary, but could you give us a little bit more information about that, please?
Yeah, I can't quote the exact numbers, although I would be able to have a look if there's a break. I'll do that for you. But we saw an improved position at the end of last year compared to the year before, marginally. And we are in what they call tier 2 of the country, so we are not in the worst quartile. We're in the second worst quartile or second best, whichever way you decide to frame it. What that means is we're around about 80th out of 134 in the country for our 4-hour wait. We know that our 12-hour waits have improved compared to last year by around 1%. However, that's not enough for us. We know that waiting that length of time in the department is not conducive to a good experience, and so we're taking those steps that I mentioned before to try to improve that experience. We've got small green shoots of improvement coming, but we've got some more work to do.
So because of the long waits, and yes, there are 12-hour waits too, how are you thinking, you can come in on this, Health Watch, please, if you would, how you can mitigate those circumstances for the patients as they wait in that corridor? Because people who are waiting in that corridor are extremely ill anyway, and they'll be showing symptoms of their illness too. They might be vomiting, they might be in excessive pain, but they're sat so close to a stranger. You know, it's really undignified. Are there such things as screens that you could put in place, or during the middle of the night, make sure the food machines for the families are working? I must say and compliment the people who take care of the facilities, because they kept them extremely clean during the course of the whole night and day. And I'd like to commend those people who are doing that lowly job, but a very vital job, because people were ill coming in and out all the time. So that's my question. Are there any physical mitigations that are being put in place to help with that experience, to make it a little more dignified, a little bit more easier for when people are so extremely ill?
Perhaps I could answer
Please,
the specifics about what we do, and then maybe my colleague might want to speak to the types of feedback that he gets around that. Is that okay? You're right. I don't think there is a way to provide true dignified care on a corridor. I wouldn't sit here and attempt to describe that. What we try to do is the best we can do in those circumstances, and there are some things that our patients do tell us matter. So the comfort, the seating, the quality of the mattresses, they all make a difference when you're sitting or lying down for a long time. And so we've actually just invested in some new seating and some mattresses. We have nurses that are based in the area where we are escalated, wherever that might be, that have got specific responsibility for those patients, so that they are not waiting for somebody to finish around the corner. They are there present on the corridor. And we've got designated spaces with numbers and advice and guidance for families about what to expect, how to contact someone if they're worried, how to call for the toilet, etc. We do have screens, however, for logistical reasons, unless somebody requires personal care, they're not routinely up on the corridor. And that is something we've been giving some thought to recently. Ideally, you'd want to put a curtain around somebody, but because of the requirement to manage fire and everything else, that's not practically possible. But we are exploring if there are ways in which we could try to give people just a little bit more privacy. What we're really focusing on, though, is trying to move away from needing to use the corridor at all, and because that would address the root cause. And so changes in modernising the way we deliver care in ambulatory settings where people come in and they might go to a seated area, so we're not deconditioning people by putting them on a trolley for 12 hours and then they get wobbly legs and dehydrated and all the things that happen when you come into hospital. We're trying to make better use of those facilities for people who are suitable to get out of using the corridors.
Yeah, I was just thinking, I know you were saying screens for toilets, for toileting, but for vomiting too. It's not very pleasant if somebody at either side is vomiting.
Yeah,
the smell, you're seeing their obvious suffering, and the person who's in the middle, you know, is suffering too because of it. So could we have some reassurances that something might just be put in place, you know, if people are excessively vomiting, please?
Yes, absolutely. So we are currently doing some work with a person who's led a really successful piece of patient experience work in another organisation. We've invited them in because they've got really good patient experience scores and we want to learn from them. And they're starting in the next couple of weeks, actually. And some of the way in which we use the corridor is part of that discussion, whereby patients that perhaps are more settled and have been seen and are stable would then go there, whereas those patients that are experiencing some of what you're describing would be moved into that area. We also know there's a lot more we can do. So it's not just about being over-occupied. We all know it's possible to make an okay experience poor if someone's attitude towards you isn't as constructive as it can be. And so I know that our teams want to provide really compassionate care, and sometimes they feel the stress of working in that environment. It's really important that we pay attention to that so that they're the best versions of themselves for the people they're caring for. And so that work, as well as that patient experience work, should lead to better outcomes, and we'll be able to see that through the friends and family scores that we publish. Complaints in the emergency department aren't really that common compared to the amount of people that come through, and I think the friends and family gives us a little bit more of a realistic indicator of whether we're getting things right for a larger number of people.
Thanks, I'm quite reassured about some of the things that you've answered as regards mitigation. Thank you. But I'll be watching.
Move on to questions to Health Watch. Can I bring in Councillor Pritchard, please?
Thank you, Chair. Thank you very much for talking about patient experiences and the feedback to you. If we can just hone in onto what people are telling you about A&E, and what can we learn from that, please?
So in preparation, we've sort of looked at the case studies and experiences that have been shared across the last 12 months. In terms of experience of accident emergency, the general feedback is of a similar picture of long waiting times, and sort of some people don't always feel informed as to where they are in that journey. Now that, when we've discussed it with Trust, is because of the sheer amount of pressure that they face. In terms of some of the stories that we've had, you know, people are going in with different conditions and different situations. Sometimes, you know, it absolutely merits the need to be an accident emergency. Sometimes there could be another choice that they could have made to go to another service, but at the time the decision was taken to go to accident emergency. So a couple of the examples that we have where people have taken loved ones into hospital, and because of the circumstances and the situation they're in, it's not a good experience. There's considerations for people such as dementia, where someone's taken a loved one in, and because of how their symptoms present, they're not aware entirely of what's going on, which causes confusion and anxiety. In terms of, sort of making what we've heard about the way the staff were, you know, we've heard examples of empathy. We've also heard examples where staff haven't always been behaving or acting in the most appropriate way, or telling people the right thing, and these are very quickly flagged to Trust to make sure that they are aware of what is actually happening. One of the sort of other examples have been where people have had questions after the fact of being in, asking why certain actions hadn't been taken, in terms of, you know, had the bloods been done, and, you know, nurses taking a while to respond. We cannot give the reassurances that they need, but where possible, we do encourage them to raise them with Trust to sort of highlight the issues. We always make the offer that, you know, we'll pass information to Trust as well to make sure that they're aware of what's going on. Like I said previously, it's always very well received and taken in the candour that it's intended, that we're not there to complain on behalf of someone, it's that we're just raising awareness of it. Generally though, patients compliment staff. The care is there, the staff all want to make sure that people get the best offer possible, and I can say that about most service providers that we hear about. I think the pressures is the thing that is the barrier, if you will. Thank you.
Thank you. I'll just come back. It was really welcoming to hear Sarah talk about the carers welcome policy and John's law. In your experience, I don't know how closely you might work with the Carers Association, and have you felt that with John's law and the carers welcome, have you seen any improvements when carers are feeding back to you about how they feel as a carer? Thank you. Thank you.
It's a little bit of a mixed picture, if I'm going to be honest with you. We did a piece of work 2024-25 looking at, it's titled Who Can Help Me? And it was aimed at looking at the experience of carers across the county. At the time, the main theme was a lack of information for the carers, and when people were going to appointments, they were talking to the carer rather than the cared for person. We did put some recommendations in place, which we have seen some movement on, in terms of making sure that staff are well trained and well versed in the rights of people who receive care from a loved one. There's been different changes across the sort of spectrum in terms of making sure that people are getting what they need. In looking at the sort of wider picture, we do go to carers groups across the county. Some groups it's different, some it depends. Some of it does depend on where they are located in the area. If we're looking at sort of central Lancashire specifically, they're very lucky that they've got the Lancashire Carers Service and other partners who are able to help. There's several different sort of charities out there, such as what was the one you got to in Pemberton? Blue Flamingo. Blue Flamingo, things like that, where, you know, people can get that advice. It's much wider advertised now. you know, what people's rights are, and on the back of different pieces of work that other partners have done, there's a lot more awareness of what to expect and what can be provided.
Thank you. Councillor Howarth.
Yeah, are there any recurring themes or concerns that Lancashire teaching hospitals haven't yet fully addressed?
I would say there's no outstanding concerns that haven't been addressed. It depends on the sort of picture at the time. Winter pressures was something that was sort of reported quite a lot around Christmas, but the Trust were already aware of the concerns that were being raised.
Thank you. Item 5C, transfer from A&E to wards. Can I bring in Councillor Jackson, please?
Before we leave that last one, can I just ask, my question that I wanted to ask about mitigations, it was answered fully, thank you. But then, what about the nurses in A&E? Would you mind if I ask that question? Are they rotated? Because psychologically there's lots of stresses and strains put on them in this stressful environment that they're working in continually, especially when it's related to corridor care. Are the nurses rotated? Do they stay for a little while and then go to another department and come back later on?
No, they don't actually. So they choose to stay for as long as they wish to stay,
Yeah.
and then could apply for another job if they wanted to in another part of the hospital. We would facilitate that. So if somebody felt that they just needed a break and they needed some other experience, there's plenty of opportunities for transfer within the hospital. Some people do that. And others really like that environment. And it's funny because to some it would seem like something that it would be difficult to enjoy working in, whereas others really thrive in it. And I think that is just the nature of people and sort of, you know, what makes them tick. I think it's clear that when colleagues are not managing the stress associated with that environment, that we've got a role to play to make sure that they are debriefed properly. They see some of the most traumatic things really in society, as you can imagine. And so we place quite a lot of emphasis and growing emphasis actually on psychological health and well-being and our role as an employer in that. Outdoor spaces, proper breaks, access to people that can debrief properly and have had correct training in which to do that, so that they don't, or they take as little as possible home with them so they can be fit enough to care.
I'm quite reassured at that, and I'm glad there's that facility if people need to change over.
Yes.
Because all our services, well, we depend on our doctors and nurses, don't we?
Yeah.
And they need to be healthy, then we can carry on and be as strong as we can in the NHS. Thank you.
Thank you.
Thank you. Councillor Peat, please.
Thank you, Chair. What are the main bottlenecks in patient flow to get from A&E through to a ward? I know you described briefly, but in your opinion, where are the sticky points on that?
The best way to think about the urgent care system is to think about it as one whole connected system, and if the discharge arrangements are not robust and patients are delayed getting out of hospital, essentially the whole hospital just backs up and then you feel the pressure in the front door. And so in some parts, patients that are waiting for ongoing care needs can account for round about 13% of the patients in our bed at any one time. So that's around about 100 people that are waiting for ongoing care needs that don't require hospital care. That's a significant factor and one that we're working very closely with the local authorities on. They're very engaged at the moment. I feel that we've got really constructive relationships and we're talking about our challenges together and how we both work in a way that doesn't shift issues or funding issues to one organisation or the other. Rather, we focus on getting the right thing for the patient that means they can have a good life at home, as I said at the beginning. The time of day plays a big factor. So often it can be that patients are discharged toward the end of the day, and that's because when the doctors come in the morning, their first priority is to see the patients that are sickest. And so they don't come in and see the patients that are ready for discharge, they come in and see those that need that expertise to save a life or to prevent deterioration. Once they've done that, they then move on to doing discharge work. And you can imagine that depending upon the amount of activity that is going on, sometimes if we've got a lot of sick patients, that then means the doctors need to preserve life, and so focus there. So we do some things to help with that though. Our pharmacists are excellent. Lots of them prescribe and they support and work alongside the doctors to make sure that we don't have the delays that we once had. They're the primary reasons, I would say.
How effective are escalation processes such as surge capacity, additional beds in reducing delays?
I would say semi-effective. I think the rise and increase in all public services means that when one part of the system is busy, the rest of the system is busy. We obviously see seasonal demands associated with winter and respiratory conditions for adults and children. We do have facilities to be able to escalate into what we would call boarded beds, or it's corridor care equivalent on the ward. That's not our preferred position, but sometimes we have to do that in order to preserve access to the emergency department. We do frequently work with system partners around areas such as mental health. We have daily calls with them where we talk about who needs what and trying to make sure that we're prioritising those that are likely to come to harm so that they move first. We've got really good arrangements with the Integrated Care Board, whereby if one of our services has to stop for a while because of staff shortages or safety reasons, that we might put out a mutual aid request. All those things help, but they don't remove the challenge at the front door, and that is an over-occupied emergency department, and that's why I would describe them as medium effectiveness.
Thank you. Councillor Howarth, please.
I think this question's already been answered, Chair. So.
Yes. Councillor Hindle-Taylor, please.
What improvements have been delivered in the past 12 months and what further changes are planned?
Would this be in relation to the emergency department? Yeah. The emergency department team have been working on earlier rapid assessment for patients from as soon as possible as they come through the door. They've been trialling different models of care, learning from those that do it best across the country. We have today, for example, had someone from NHS England come in to give some feedback to the team about the way in which the acute medical team are organised to try to look at the hours that they work to try to provide bigger services, more hours of coverage from 7 in the morning until 10 at night, whereas at the moment they currently start at 9 o'clock and finish at 8 o'clock. So we've looked at what we would call decision makers at the front door. So we know the sooner a patient gets to see a senior decision maker, the quicker the right decision will be made and that patient will be diagnosed, treated and then discharged. We've also been looking at things like seating and we've just spent quite a significant amount of money on improving the seating so that patients don't get pressure ulcers whilst waiting in ED for prolonged periods of time, and that their comfort is maximised when they do have to wait. We also work with the urgent care provider, GTD, to try to make sure that patients with minor injury presentations go through to GTD, and their performance is our performance as a system, and they're seeing more patients within 4 hours now than they were doing this time last year, which is really positive. We've also seen a really positive increase in the number of permanent registered nurses and doctors that have been recruited to both emergency departments, and the staff tell us that that's important, so they're not working with lots of bank and agency people, and so they get to know and have a rapport and develop good team spirit and standards of care. They're some of the highlights.
Thank you. Councillor Green, please.
Thanks, Chairman. Can I ask what feedback Health Watch has received from patients and families about delays in transfer and the associated impact on their care?
Yes, thank you. So some of the examples I've already previously used where people have been waiting to be seen by a member of staff to be triaged. Some of the case studies we've taken on have sort of explained how they've got to the first triage bit within sort of 15-20 minute window, and it's the bit afterwards where they're waiting to go to the next step, which has already been sort of explained by Professor Morrison, is part of the sort of long chain of care. Generally though, people tend to understand why it is the way it is, and what we try to do is sort of inform people of other options that are available to them, such as, you know, if something requires a pharmacy first referral, we can say you can use that service rather than needing to go to A&E. It does depend quite a lot on the situation they're in, but in terms of sort of the question, some of the examples I've already given sort of go some way to explain that situation, but most of the time the feedback is around sort of communication. You know, do patients know where they are in their journey?
Agenda item 5D, patient care on wards. Councillor Pritchard, please.
Thank you, Chair. It was really encouraging to hear Professor Morrison talk about the improvements in chairs and being able to reduce ulceration. I'd just like to ask you what your current key quality indicators are regarding falls, pressure ulcers, infection rates, and do you have any areas of particular concern? Thank you.
Yes, thank you. Clostridium difficile infections have been an area of concern for the Trust for the last 2 years. This is an infection that is in the gut that causes quite significant unpleasant symptoms of a gastrointestinal nature for patients, and it is a multifactorial problem, in part due to cleaning, antibiotic use and frailty. We've undertaken a really significant piece of work in the last couple of years around improving standards of cleanliness, ensuring antimicrobial use is appropriate, and education, and we have for the last 2 years come in under the maximum tolerance permitted by NHS England, and that's a real team effort actually across a lot of different areas. We know that we're more susceptible to those because patients with cancer and renal conditions are more likely to suffer from those types of infections, and because of our specialist services, that's some of why, if you look at the national tables, the places that have the services that we have are all in the higher numbers. Nonetheless, we've definitely shown that we can do something about that. From a falls perspective, we've seen the overall number of falls increase from this year to last year, but we've seen the level of harm reduce, which is positive, and that is as a result of using different pieces of equipment and different methods to try to minimise the impact of a fall if it does happen. Of course, we're still continuing to make sure that that doesn't happen. From a maternity and neonatal perspective, we look at things like induction of labour times, the number of postpartum hemorrhages, and that's a mixed picture. So we know that women do get frustrated by the time they need to wait to be inducted to have the baby, and that is as a result of the delivery suite being busy and needing to safely manage the number of people in labour because they have one-to-one care in labour. That is a national standard and we are completely compliant with that, which is really positive because there's a lot of evidence to suggest that leads to positive outcomes for mums and babies. We have, for the last 7 consecutive years, achieved what's called the CNST standards. These are the Clinical Negligence Scheme for Trust standards for maternity safety. And that is, it says there are 10, but in truth there's probably about 100 different standards because each one of the 10 has numerous standards. But we take that really seriously because that's all evidence-based. It comes out from the mother and baby mortality reviews nationally, and we have again declared compliance, which is excellent. The standards change every year in response to learning from poor outcomes for mums and babies, and so we see that as an absolute key priority. From a general inpatient perspective, pressure ulcers are our area of focus at the moment. So we have seen the number of pressure ulcers increase and the complexity of those pressure ulcers, and that's our actual #1 priority at the moment. It is a multitude of factors that affects that: frailty, increasing age of the population, diet and fluids, mobility, but we do know that urgent care delay and the time spent in chairs or trolleys, not in a bed, does impact the quality of care that they receive, and so that's again why that urgent care work is so important.
Councillor Jackson, please.
I think we've gone on from A&E now, so I'll decline that question. Thank you. I'll take opportunity at another time.
Okay. How do you ensure continuity of care when wards are under pressure, including the use of temporary staff and temporary wards?
So we have no temporary wards open anymore. We took the decision to close those, and that was in part because sometimes more beds isn't the answer. We have tried a number of approaches and actually found that opening more beds can often actually just extend patients' length of stay in hospital because we're further diluting the number of decision makers to see those patients. So instead, we're focused on trying to make that length of stay as short as possible, optimised for that patient, and that they get good quality information and go home treated. From a fill rate perspective, all of the wards have set staffing levels that are reviewed twice a year. There's a national quality board for NHS England, and they've set the standards, which are fantastic actually as a registered nurse, because they make it very easy for me to say this is how to assess safe staffing, this is the methodology, and this is what you should do, and we're fully compliant with that and have been tested on numerous occasions in the last few years. The fill rate is consistently above 98%. However, the variability of bank staff is what does place pressure, and so I do understand the question. We have a good fill rate of bank staff, as evidenced in the overall fill rate, and we know that some bank staff choose to work on bank because that suits their lives, and they work in the same areas, and that means those areas do get some consistency actually, and the bank is a really valuable part of our offer as a hospital and an employment option for people. However, staff don't like to move departments, and when they have to move departments due to sickness or pressures, that does cause people to be quite unhappy. And so there is an element of the bank that is quite useful in offsetting some of that. We've currently got more healthcare assistant vacancies than we had this time last year, and we have got a concerted effort on at the moment to reduce that by 100, because we know that we can tolerate around about 100 vacancies from a healthcare assistant perspective. But once we get up to the levels that we're at now, which is about 170, we know that that starts to have an impact on continuity of care. And so we are addressing that in partnership with the local further education establishments to try to make the hospital look like a good employment option.
Thank you. Councillor Pritchard, please.
Thank you, Chair. Moving on to sort of the discharge of patients from wards, how are patients and their carers kept informed about their care plans and the discharge expectations? Thank you.
As I said before, we have a discharge facilitator service and a specialist discharge team. So anyone that has complex needs would be seen through that team. So we make sure that we've got expertise that understand options for people. We know that that is really important and that it can be really daunting to try to navigate your way out of hospital if you've got complex needs. Every ward has a ward manager, and the expectation of that ward manager is that they know their business on the ward, they understand their patients, their length of stay, what they're waiting for, and that they're monitoring that every day. We know that we don't always get that right, and this is a place that we do need to focus more on. But the main point really is to involve the patients in the ward rounds so that they understand what their plan is and how to plan for home, and that we're involving families right from the very start. So from the minute people get on the ward to both manage expectations and manage some of the logistics that people need to do to get home.
Just questions to Health Watch. I've got two questions. I'm going to try and put them together if that's okay. It was about what the feedback that you're receiving from patients about the best and the worst, if you like, with regard to ward-based care. And then were there any specific wards or conditions or cohorts that actually stand out, whether that's really, really good or maybe not so good? Thank you.
I can certainly answer the best and worst side of things. In terms of specific wards, I don't have any information on particular areas other than accident and emergency. Generally, across the feedback we've received, the sentiment is that the hospital services are of a satisfactory standard in that sense. In terms of the best and worst, generally the best examples are where staff are very person-centred. They take the time to make sure that patients are listened to and heard, and also that the relatives are given that consideration as well, because any stay in hospital is an emotive time, so ultimately it's not just about the person in the bed, it's the family's needs as well. Some of the best examples we've had are where people have they've been taken in with some severe concerns. One example being of a person who had a problem with the spine, and at the stage of life the whole family was quite concerned about potential ramifications for home care and whether there were actually going to be further issues in terms of their health. One thing that did come through in that story was that patients were sort of talked to as though they were a human being. They weren't just a number or a space in a bed by various members of the team, particularly accident emergency. When they were in a long wait, one member of staff was credited as it was a hot day. They brought them an extra glass of water, and they asked the relatives if they wanted a glass of water. Little things like that. They do go a long way to make sure that people have a good experience. So they're the positives in terms of, people do feel they receive good person-centred care, which is something that all trusts I know aspire to deliver. Where the sort of worst examples are is generally, I'll give you the themes, I won't give you any specifics, but the themes where there are issues generally stem from a miscommunication or poor communication, where someone has got the wrong interpretation of a discharge plan, or they feel that the process has moved a little bit too quickly for their liking. So one example was someone who needed to go home was potentially having to have a social care assessment. The family was concerned that the trust hadn't spoken to the social care assessment team. They had, but they didn't know that it happened. So it's little things like that that sort of do bring out that side of things. Fortunately, we're very lucky in that we've never heard anything serious that required any major escalations, and I consider that to be a blessing. But where issues do arise, communication is one element. One element that does sort of sometimes crop up is around staff attitude. If they are under pressure or they're not familiar with them, that does sort of raise some concerns in terms of, you know, continuity of care. Do I know this person who's come to see me? Have they introduced themselves? But as I said, we've never had any major issues referred to us, and anything that sort of does sort of count as a need to make a complaint, we always direct them to make contact with the trust through the PALS service so that the learning can be made. Thank you.
Thank you for that. Agenda item 5E, integration between health and social care. Can I bring in Councillor Howarth, please?
Yeah, how many patients are currently medically fit for discharge but remain in hospital, and how has this trend changed?
So there is currently anywhere between 90 and 120 patients who are medically fit for discharge. The trend has deteriorated in recent years, in part due to access to intermediate care. This is an area that we're working on with the local authority. The Director of Adult Social Care and I have actually had 2 meetings today on this very topic, and we have a really constructive relationship genuinely in this area. We recognise that we've all got a role to play here in making sure that patients are seen as quickly as possible so that they are not deconditioning and they don't need more and more care, and that's better for the patient and it's better for the local authority. And we're also working together to make sure that the intermediate care offer is stronger across central Lancashire.
Thank you for that. What are the main causes of delayed discharge? Is it care packages, assessments, housing issues, or something else? Thank you.
So it really does vary and include all of those things. Predominantly, patients with higher level of care needs are the most difficult to find a suitable placement. So complex dementia, behavioural challenges, spinal or airway issues, as you would imagine. But they are relatively low in numbers. It's just that they unfortunately do tend to wait longer than any other group of patients. Our patients that are awaiting mental health inpatient care do also wait a reasonably significant amount of time, and in part that's due to the care closer to home agenda that's been encouraged nationally for all the right reasons. It is better for people to be near their families, but it does mean then that people are waiting longer in hospital in order to access the care closer to home. We have recently had a CQC inspection that did identify that as an area that requires improvement in our area, and we are working with the Lancashire and South Cumbria Trust to improve that.
Thank you. Can I bring in Councillor Pritchard, please?
Thank you, Chair. In progressing the discharge plan, how effective are the integrated team that actually come together to progress that, please?
The teams work actually really well together. They've got good relationships. Different organisations don't necessarily mean that they work in silos. I think we, in health, social, community, learning disabilities, mental health services, we understand that if we don't work together, the patients do really suffer. And so we have a number of forums. We speak daily, actually, to our main providers, mental health, social care. Where there is a learning disability patient, for example, there's a team around that patient. It's absolutely normal for us to pick the phone up and speak to that team who are that patient's advocate do a fantastic job. Actually, that's probably one of the best examples that we've got. The teams really do work seamlessly across that pathway in a really well integrated way. Of course, we can always do things better. We've taken some steps recently to have social workers in ED at the front door. That's made a tremendous difference to easing communication, not needing to do a referral in the same way that we might have done. We simply have a conversation, we hand over the patient, or we assess the patient together in a dual way rather than doing one and then passing to another. So it is an area that will always need focus, making sure that patients don't have to approach 5 or 6 different people in order to get what they need done. I think it's incumbent upon us to try to make that a reality for everybody. But I've got to say, we've got really good system relationships in this area, and I have experienced places that haven't. So I feel like I can judge what good feels like.
Thank you. Councillor Green, please.
My question's already been answered, Chairman. Thank you.
Thank you, Councillor Green. Agenda item 5F, plans to tackle waiting lists for treatment. What is the current waiting list size in Lancashire?
We currently have 60,000 people on a waiting list in Lancashire. That's 1,000 less people than what we had in the previous month. I should say that is for Lancashire and South Cumbria specialist services, as well as the local District General Hospital offer.
And so that's 1,000 less than last month, did you say?
Yeah, so
right.
For May we had 60,000 and for April we had 61,000.
Right. Thank you for that. Councillor Jackson, please.
I wonder if I could ask, what progress are you making to meet national recovery targets, please? And where are the key risks?
Okay, so from an emergency department perspective, we have demonstrated an improvement in the last month. We are, in fact, I've just got a slide that will just help me answer this absolutely accurately. So if you could just bear with me one moment. So our performance in May for the 4-hour standard was 70.3% versus a target of 69.9%. For 12 hours, we performed better than expected in May at 10.35% of patients waiting more than 12 hours, and that was compared to April position of 12.75%. For referral to treatment time, we achieved 60,428 people versus a target of 64,000. So that is an area that does require improvement. And for patients that have waited longer than 52 weeks, which is a year and is significant, we have got 815 patients currently waiting 52 weeks versus a target of 1,353, and so we are performing much better in that area. Have made really positive improvements. We've got no patients waiting over 65 weeks now, which again is a significant recovery. From a cancer perspective, we're achieving 78.6% versus an 80% target, and that continues to be a really important area for us, and that's the faster diagnosis standard. So that's about trying to make sure that patients know if they have or have not got cancer as quickly as possible, because we know that that makes a big impact to how they feel. We're achieving for 62 days a 63% versus a 65% target, so we're almost at that target. And for 31 days, we're at 91.7% of people achieving what they need versus a target of 94%. And again, we've made really positive progress. These are annual targets, And so by the year end, we do anticipate to have met all of those standards that I've just described to you.
Lots of hard work.
I'm so
there.
glad I brought that slide.
Thank you for that. Would you be able to send that slide across to us just so we can compare with the national average? Councillor Michael Green, please.
Thanks, Chairman. Just to comment on that, it's really pleasing to see that we're making good progress, but nevertheless we are still below target. And those targets are national targets, so we'd truly be hoping to surpass those moving forward. So we look forward to even further progress moving forward. Just looking at this, so what specific actions are delivering the greatest reductions in waiting times?
So it really depends by specialty. There are some instances where patients can be seen in groups rather than being seen individually, and that helps the intervention be effective, such as therapy, for example, where it might be appropriate for people to be brought together to have certain treatments, I don't know, around back pain, for example. Some is about making sure that the patient is on the right list. So we might find patients that are on multiple specialties if they've got really complex healthcare, and that's about a clinician looking at the patient, understanding what they need and getting them to the right patient more quickly. For places like endoscopy, we've done a really important piece of improvement work where we've looked at maximising the use of the rooms and making sure that we've got the right amount of patients on the list so we're not wasting a minute. And that productivity element is really important for all areas where rooms and procedures are undertaken, such as theatres, outpatient departments, endoscopy, heart scans, etc. And so lots and lots of what we've done has been around focusing about making sure that we use what we've got really well, and then also putting on additional activity. So accessing modes for care, such as the MRI scanners on wheels, where we might engage with other providers to provide care that can be given more quickly for people, using places like Greater Lancashire Hospital, for example, for more simple hips and knees that can be done in that setting. That means that the complex patients would still remain in Lancashire teaching hospitals, but it means that other people who are suitable can access treatment through different modes. And it is that collection of things that is really making the difference.
Councillor Green.
Thanks, Jim. Just looking longer term, so I realise obviously the NHS and providers such as social care providers, the county council, in our case locally, you're often faced with fighting fires and putting fires out. It's often, if I can put it that way, what your priority is. But thinking longer term, how much more could the NHS, yourselves, the county council and so on do in terms of the prevention agenda? So starting to tackle issues further upstream so that we try to prevent people getting some of the illnesses which then have a big impact. I think I'll just take one example, diabetes for instance, which is a critical illness and is projected to become significantly worse in the years to come due to people's diets and things of that nature. So how much are you doing currently working with partners, and how much more could you do to start to address this so that we see a longer term dip rather than an increase in some of these issues?
So I think nationally the focus around health inequalities has been really helpful because it has shone the light on the importance of public health, which I think has been put on the back foot for a number of years. In the hospital, we use Core 20+5, which is a set of national target areas that were most likely to be able to be affected in the hospital setting for adults and for children. Of course, obesity, smoking, alcohol, all feature as primary drivers of poor health outcomes for people, and that's worse in protected groups and people in lower socio-economic environments. We've got a role to play in that in terms of making every contact count. So we have a health improvement plan, and that is focused around making sure that screening is undertaken for those areas that I've described. So we've prioritised smoking and alcohol for the last 2 years, and we are now up at over 80% of patients being screened for smoking and alcohol when they come into hospital. I think smoking is something that we're all very aware of, and being able to access nicotine replacement therapy, often an exacerbation of an illness, can be the time that you can have a positive intervention for somebody to decide to change their lifestyle. Not every time, but it can. There is an evidence base that suggests that. Alcohol is something that is much more hidden within our society, and whilst we might have individuals with extreme alcohol abuse, sometimes there are early signs that you can see in a hospital setting where a critical conversation can really make the difference between somebody deteriorating and really losing facets of their life that are really important. And we paid a great deal of attention to that, with a lot of success, with people being seen and referred on to services that can really make a difference and turn people's lives around. We do less about psychological well-being, and we do less about obesity at the moment, and they're going to be our next areas of focus. I've personally worked quite closely with our Director of Public Health, and he helped shape our health prevention plan, which I think is right. It's we shouldn't be doing extra things. We should be working with the local authority and deciding what we do to complement those things. Equally, whilst we've not managed to mobilise this yet, we've talked a lot about making sure that people who are entitled to benefits can access benefits. And again, that's not something that has traditionally been done in health, but you can often see people who are struggling when they come in with a health condition. And so Sakthi and I have been talking about what we might do to make sure that people who are entitled to things get them, because we know that that is a pathway to improving outcomes for people. There's lots more, but I'll stop at that.
Yeah, thank you. And that's very positive. Just, I don't want to open up all new discussion, but at the moment we're currently potentially face the threat of local government reorganisation, which will mean the county council wouldn't exist anymore. We'd have a number of unitary councils, etc. So how confident are you that you can push this forward, this prevention agenda forward, with the new unitary councils if and when they are established, to make sure that we don't drop the ball and indeed use it as an opportunity to push this further forward and do more on this important area?
I mean, we will work with whatever configuration is in place, and I would like to think that however the arrangements are operationalised, that there would be the focus around public health. That would be needed in whatever configuration that we've got. It helps us in the hospital having a Director of Public Health. I think that that is a fundamental appointment, not least because of the expertise, because you could waste an awful lot of time doing things that actually don't make a bigger difference. And as a system, we have to be focused on those key drivers of health and be doing them for quite a long time in quite a consistent way for them to actually have a difference to somebody's lifestyle and then their outcome. I say that there are a couple of exceptions to that. So I think children are an exception to that, because you get a relatively quick rate of return for interventions with families, and I would like to see more attention to that. If we have healthy children, we'll have healthier adults. And maternity, you've got 9 months where you can work with women to have really healthy babies and healthy maternity periods, and they are the maternity incentive scheme I talked about before. That is some of that, but I think we could do more in those two areas for children and pregnant people.
Thank you for that. Councillor Hindle-Taylor, please.
What impact are workforce shortages having on your recovery plans?
Thank you. We're in a really privileged position that I've never known in my career, in that we really aren't struggling at all to recruit registered nurses, midwives and some allied health professions. There are some more specialised allied health professions, such as sonography, that do present a recruitment challenge for us, and that is causing a delay for patients. We have got good relationships with the local universities, and where we've got shortages, they're often duplicated nationally, and so there are good programmes of work whereby we're now looking to undertake an increase in students for sonography, so that ultrasounds can be done. It does take round about 4 years in which to do that, but because there's quite small numbers of them, unlike nurses and midwives, you can make an intervention, and within a relatively short period of time that can help. From a medical perspective, because we are the tertiary provider, the specialist provider, we actually don't struggle to recruit surgeons at all. We've got a really good reputation, and people want to come and work here because it's highly specialised. We've got a good research and education offer, and that's really appealing to surgeons. Medically, we do struggle more, so things like frailty, care of the elderly, acute medicine doctors, they're difficult nationally to recruit. So the Royal Colleges and health education, no, it's not health education, NHS England are changing the sort of way they train doctors so that we get more generalists in the future, because there is a school of thought that specialising everybody has made the general specialties less attractive. So the first set of those sort of generalised hospital doctors, a bit like general practitioners in the community, if you will, I think it's in 2 years they'll start to come out of university. I think that will really help. In the meantime, we use extra hours for staff, which can put them under pressure, and also bank and agency, which is obviously much more expensive and not ideal. But we've done quite a lot of work to develop what we call advanced clinical practitioners. So they are nurses, midwives or AHPs that then go on to do extra training to prescribe and to be able to assess patients using the medical model, so that we then move in the medics to where only they can work. And that has we've had some good success with that, but it is a challenge.
These next few questions are for Health Watch. What concerns are patients raising about waiting times, communication and uncertainty?
Thank you. So in terms of waiting times, generally people have issues related to the length of time it takes for a referral to be completed, in particular where there is a need for a specialist provision or something that doesn't necessarily fit the norm, as so to speak. The issues that sort of link with that really around the communication. So some people do get a wait time of say something like 18 weeks, and in that period of time there's there's no communication from providers. Sometimes it's that they just want to know where they are in the queue. Other issues we've recently heard about where like there's a severe specialist need. So an example being someone who needs a cochlear implant. They're not quite within criteria, so they want to know where they stand. And there's a need to sort of educate them around why they are where they are and why it's perhaps not the best option for them. So there's some of the things that are related to the referral side of things. In terms of... could you repeat the second part of the question, sorry? I've lost my train of thought.
Sorry, it was waiting times, communication and uncertainty.
Yeah. So there's quite a few things, pieces of work that have been done in terms of improving the communication between patients and staff, particularly elements related to letters. The Trust, I know, has a very, very positive working relationship with the Visual Impairment Forum for Lancashire. We're also active participants of that forum, where the chair and other members of the group are invited in to look at the communication to make sure it's of an accessible standard for people with visual impairments. Generally though, the issues that do come up are always taken as a point of learning for anybody who is in that that field. Even ourselves, where we've looked at our communication, someone's flagged something up, a change is made, and that does happen. Generally, though, communication is a bit hit and miss depending on where people are, and it's also about how people have things explained to them. So one of the things that I'm sure clinicians are always sort of discussing and sort of having a go at themselves for, is the use of jargon. A lot of people consider NHS speak to be a little bit inaccessible, and I know that there's initiatives in place to address that. Sometimes, I mean, even ourselves, we do jump into acronyms and things like the ICB, and you have to pause and go, the Integrated Care Board. So that's the sort of issues with communication. Generally, though, patients do feel sometimes that they can't ask questions, and it's not unique to one setting. We mentioned before about people raising complaints, having some sort of hesitancy in doing that because they feel there'll be some sort of repercussions. That's the communication barrier, where people don't feel like the system necessarily works in their favour. So it's our job to identify the alternative avenues that they can take, and trusts also have sort of initiatives in place, such as the Patient Advice Liaison Service, missed the acronym that time, to make sure that people are aware of, how they can communicate with services. Ultimately, when people are in hospital, like I said before, it is an emotive time. Sometimes it's not always clear what's going on. They may need an advocate or someone to listen on their behalf. So that's some of the barriers that we've had. In terms of uncertainty, I suppose any interaction with a medical service poses a level of uncertainty. You go in thinking you've got one problem, you come out and perhaps potentially with the diagnosis of another, which does create that fear and uncertainty, for want of a better word. So yeah, but we found that people always work the best to answer those questions. It's just about giving people the confidence to ask.
Brilliant, thank you. Councillor Howarth, please.
Are there groups of patients who are disproportionately affected by long waits?
Do you like me to answer?
Please,
yeah. Yeah. Yes, there are, and that would be older people aged 65 and above. Older people, I said.
Item 5G, patient voice experience and responsiveness. How do you gather patient feedback across A&E, wards and outpatient services?
Okay, thank you. So we use the Friends and Family mechanism routinely for interactions in all of those areas, and patients are issued either with a piece of paper when they come in. We have people going around and collecting that in writing for people that can't do that themselves, and then there's a text message service. Overall, we see that the emergency department performs on or around the average of the rest of the country. Outpatients is the same and is reasonably positive. Maternity performs in the top quartile of the country, as does the cancer services. And that triangulates with the national PICA surveys. So they're the mandated surveys by the CQC, the Care Quality Commission, they tell us whether our services are about the same or worse or better than others. Our best performing areas, as I've said, are cancer and maternity. Those that are in the middle of the pack are children's and the emergency department, and those that are in the lowest quartile are the inpatient areas. And that aligns to some of the delays in the urgent care stuff that we talked about before. Other ways are through patient stories. We start every board meeting with a patient story and try to focus more on patients who are in protected groups, because we know that they are disproportionately affected. Recently, we welcomed a patient who had had a thrombectomy 2 weeks prior for a stroke. That's a blood clot removed from their brain. And he was sat in the board meeting sharing his experience of why that service was so important. It was absolutely amazing. and it really told the board why the whole multidisciplinary team is important, from therapy to doctors to scanning to surgeons to nurses. They gave us some wonderful feedback, and it was great because that has been an area of concern for the general public, being able to access that during certain hours of the day. Prior to that, we had a patient with a diagnosis of Down syndrome that had been frightened to access treatment for their eyesight, and he had subsequently, as a result of outstanding personalised care actually, had come in and had his eyesight addressed and could now see. And so we try to use the experience to influence the board to understand that what we do really does have an impact on patients as human beings. And that's my favourite part, actually. We also have a quality assurance process. So every month, matrons from different areas go into other areas and they ask patients, do you feel safe? Do you feel cared for? Have you been told what your plan is? We have some mandated questions every month, and then that's tested by an independent team. Depending upon the outcome, it's risk adjusted to the frequency that that's tested. And we've got a whole section specifically dedicated to patient experience. We then bring all those things together, and typically areas that are performing well for patient experience will be performing well for everything. We know it is such an indicator of general outcomes, and that's why we've decided to do that work with the person who has worked elsewhere and done that really well, because we can see that actually if we focus on experience, the rest will all fall into place. Pass to you, if that's okay.
I'll pass to
Yeah, I'll take this one. Yeah, just on part of Health Watch side, obviously we amplify the patient voice. So we do this in different ways, like you just mentioned, like the patient story. So we'll go out on engagement in general engagements. We do like libraries, food banks, community centres, literally anywhere that'll have us, we will go. We try and get across the whole of Lancashire to try and encompass, like I said, different areas that we might be hard to reach. So we'll go to like dementia groups, we'll do carer support, literally anything that will just try and get that support out there. We do a lot of in-hospital support as well, so we'll do pop-ups in the hospitals. We're quite frequent in Chorley and Preston. So we do pop-ups and we regularly feed this information back to the Trust on their patient experience meetings. So every month I'll sit on their patient experience meeting and I'll explain to them what we've heard that month, along with the pop-up as well, so from general engagement and from the hospital, all in one, and then we'll literally discuss everything that's happened. And then they'll put an action plan in place to kind of say, actually, either we're already looking at this, something we're already aware of, or actually we've not heard of that, what can we do to support you, or what is it that we need to do on our side? Like I said, we do ward visits as well, so I know last year we did a piece of work around women's health, and one of the main concerns that came up was around gynaecology, specifically at Preston Hospital. So we actually worked with the hospital and we did what we call an entry review. So we went into the hospital, went into the gynaecology department, and we did a full entry review. So we spoke to patients, spoke to staff, and it really highlighted what their concerns were with around like wait times, care that they've received, aftercare, like literally the whole package, really, from getting the hospital letter to getting there, everything. And then after this visit, we wrote a report and we put multiple recommendations in place. This was then followed up, and we got that communication back from the hospital and reassured us that what they'd done was already, either some of it had already been actioned or some of it was actually still ongoing, which was really, really good for us. And I know, like I said, like we mentioned before as well, we are very patient-led. So obviously if we're out in the community and we're hearing what patients want, like with the hospital discharge, this is something that's come up quite recently for us as well. So this is something we've obviously wanted to explore a lot further in the coming months, hopefully. No, thank you.
Brilliant, thank you very much for that. Councillor Pritchard.
Yeah, thank you. That's, really, it's my favourite bit of the whole evening that you've talked about, the lived experience coming onto the board. I think that's amazing. Just going back to the friends and family interaction, I know we talked at the start of the meeting about it's improving data and improving intelligence, and I'm not wanting to put you on the spot here, but would you have a rough idea of the percentage of those forms that are actually completed in terms of how many are given out? Thank you.
couldn't say for sure. I'll be able to look. So as we move on, if you don't mind, if you could come back, I could confirm that. We know that there is a direct correlation, though, with the greater number of responses we receive, the more positive the overall outcome is. So we are reassured that, notwithstanding that those individuals that don't have an experience that they would have wanted are more likely to fill a form in. We know that, that's human nature. We do know that overall our experience is broadly positive, but there are those experiences that go undocumented, and we've always to be mindful of that for the reasons we've discussed tonight. But I can get you the exact amount in just a minute. Yeah. You can move on.
Yeah, thank you, Chair. Emmy's actually answered very much the question I was going to ask, which was about how feedback leads to measurable service improvements, but you've done that. And I just wondered if I could ask if there's any significant areas that you could give us an idea where this feedback has led to a significant change in a policy. Thank you.
So just to answer the previous question, in 25-26 we had 69,000 friends and family feedback responses compared to 65,000 the year before. So that was a 5.43% increase on the previous year. We have really pushed areas to improve the response rates, and we saw 51,800 text responses, 15,500 paper surveys, 1,200 online surveys and 404 telephone surveys. So really good, rich amount of feedback. Where feedback has led to improvements. From a maternity perspective, women were telling us that overall their experience of care was good, but they felt the antenatal period, the bit before they have the baby, was the area that could be improved because they wanted more time with midwives to ask more questions and to have more advice and guidance. And so in response to that, we changed the way we did antenatal clinics and have increased the amount of time and the ability to access and answer questions. And that was tested in the last survey, and that had improved from the time before, so that was really pleasing. In addition to that, we've also introduced continuity of carer, where women who are at higher risks in certain groups have access to the same midwife more often, so that they can establish a rapport, build trust, and then they're more likely to share things that might put them at risk, or if they feel vulnerable, asking questions. That continuity and recognising people makes it more likely for people to do that. That's been really positive. Induction of labour, something that I talked about earlier, is an improvement project that we're working on at the moment, so hopefully next year I'll be able to tell you the same thing has happened. For people with learning disabilities, we know that the connection with the hospital before you come in for your appointment or your surgery is critical. So we just held our annual Our Health Day just last week, where there was all different stations set up in the Life Centre at Chorley, whereby people could come in and follow different colours for different areas of the hospital. So emergency care had one, outpatients had another, theatres had another. And that gave us an opportunity to connect with the community who wanted to come in and see what the hospital was like before coming in, and that helped them alleviate fears about what it might be coming through the door, needles, other types of interventions. We've seen some really good results with that, whereby now homes or patient advocates will ring ahead, and then people like Francis that I referred to earlier, and I can use his name because it was in the public and he gave us permission to do that, where he spent 2 or 3 sessions having a video before he came in, and that meant that he was familiar with the environment and he felt able to come and have his eye surgery. I see that more and more, and we see people understand the adjustments that are needed for different parts of our population in a way that I've not seen historically. So that's a real confidence boost for true individualised care. We know we don't get it right for everybody though, and we know that people listening to this, you know, will say, well, I didn't experience that. I would say come and speak to us, you know, because we absolutely do take that really seriously.
Apologies, it took me a minute to collect my thoughts on that one. So in terms of examples, there's a few brief ones that I can give. I gave the BSL interpreters example earlier. One piece of work that we're particularly proud of in the last 12 months was a piece looking at women's health inequalities and barriers that they were experiencing. And on the back of that, the feedback was concerning issues relating to menopause awareness and attitudes of staff towards people going through that situation. And on the back of those recommendations, the ICB made a commitment to improve the training offer. In particular, that group in particular, where they said they would set out a programme of training. We actually hosted one of those sessions this morning. 20 people in 33 plus degree heat. Was fun. But it went very well, and it was very well received. That, you know, the piece of work had, you know, generated that kind of outcome. We looked at maternity care in coordination with the Maternity and Neonatal Voices Partnership. We've done that piece of work with them over the last 2-3 years because Health Watch Lancashire actually hosts that partnership. We initially did some piece of work doing our visits to the maternity services, the birthing centre at Chorley, and the antenatal clinic at Preston. On the back of that, there's been a lot of feedback around things like Badger app, which is how people communicate, improving signage and just looking at overall wait times. And on the back of that, there have been some positive steps. We evidenced this through a revisit to the services last year, and there are reports in the public domain which sort of show the impact of what was observed. Thank you.
Councillor Pritchard.
Yeah, thank you. I just wanted to come back in just to say thank you, because that was really comprehensive and really encouraging. So thank you very much.
The next few questions are for Health Watch. Councillor Green, please.
Thanks, Chairman. So, how effective is engagement with the Trust from your perspective, and are you seeing genuine co-production or consultation?
I'll happily take this because it's me, so it makes sense. But no, I find the communication really good. I think the partnership between us and the patient team, I think I find it really productive. So I've got a really good relationship with the patient experience lead at Preston and Chorley Hospital. She's incredible. To be honest, I think sometimes it can be that we have patients coming to us with, like you were talking about before, that might have really big concerns but don't want to flag it to the Trust themselves. So they'll come through us anonymously, and we can actually get that feedback to the Trust in a way that, yeah, they might not want to come in person and put their name, date of birth, everything to it, but they're quite comfortable coming through us, and we can give them that feedback directly, even though it doesn't have the name next to it, doesn't have the date of birth. They know the ward, they know when it was. So in a way they can get that information, but it doesn't have to come from the patient. So it's a really vital, I think we've got a really good partnership personally, because I think there's a lot of things, like we were saying before with the friends and family test. A lot of patients are really worried. We've had patients in the past, bless them, that have said like, oh, we're worried we're going to get a red flag on our file because we're going to complain. And I get it, there's a lot of concerns, but I think this is why the partnership works really well with the Trust and Health Watch, because we can bring that anonymous feedback, we can give that direct feedback that a lot of patients might not want to give to the Trust, but it's so vital that they know about it, because if they don't know, they can't make the changes. So I think for us, I think the partnership is really strong, because I can go to them anytime, doesn't have to be just in that meeting. We have regular back and forth, and sometimes they'll contact me and say like, we're hearing this, are you hearing it? So it might be actually they're hearing something, we might not be hearing it, so it's something that we can go and look into in more detail and kind of say actually they're hearing it, but is it something that they're directly going to if they don't want to talk to us, or opposite way around. So I think I personally, the partnership is really strong.
That's very positive to hear. Very good that you've got such a good communication and relationship with them. Moving on to agenda item 5H, proposed new hospital site at Kewarden. Councillor Michael Green, please.
Yes, thank you. So obviously we've had delays to the development of a new hospital for the central Lancashire area. But could you just update us, please, on what is the current status of the proposed development at Kewarden, including funding and approval milestones?
I can tell you what I know, which is that we've got the land purchased available to build the new hospital, and that the Trust is doing all it can to influence being reprioritised up the list so that we could start the new build as soon as possible. We are in a position to be able to do that. We do have the support of the local MPs who are lobbying on our behalf to try to influence that, which is really welcomed. We are not yet in a position to be able to articulate the exact year when building will commence.
Thank you, which is not your fault, but that's obviously a disappointing response in terms of providing services to local residents in this area. And I'm sure it's a disappointing position that you find yourselves in. So what are you actually doing in the meantime? Because as great as the hospitals that you provide are in terms of providing services to patients, they're putting it bluntly, not fit for purpose in a modern world in terms of providing modern standards of service, equipment, reception for patients, things like environmental benefits and so on. The buildings are not fit for purpose. We're all aware of that. So what are we doing in the meantime to provide as good a standard of service as we possibly can until a new hospital is in place?
There's around about £50 million worth of backlog maintenance required for the estates, which at the moment we don't have the capital funds to be able to address that. However, we have been allocated around about 35 million to upgrade the Preston site ward block, because that is the highest priority in terms of estates backlog for windows, ventilation, fire, water safety and sewerage. That work has commenced in the planning phase, and we've been given the instruction that we're able to draw down the capital money to start that work. That will require re-providing some of those wards in a different area whilst we do that, which will cause quite a lot of disruption and need quite meticulous planning in order to do that. So we're currently working through how we will do that. For the Chorley site, the Chorley estate is in a much better condition than the Royal Preston site, but nonetheless it is quite aged and it does need continued care and attention. We obviously have all the normal estates and facilities services, and we would keep on top of things that are lower level in order to try to prevent those deteriorating. And then we'll have a capital plan to improve the estate based on risk. So we approach it using the risk register and prioritise that. That isn't always just on the estate. It is also based on patient feedback, on how services are changing. And we have to get ourselves ready for the new hospital. Hospital 2.0, I think they refer to it as, is designed in a certain way that reflects what a modern healthcare service needs to look like. So that means care closer to home, care delivered in different ways. And so we are getting ourselves ready by transforming our services now so that we are fit for the future when that comes. That will require a whole system approach, as lots of what we've talked about today does.
Councillor Jackson.
I was reassured to hear then that £35 million has been supplied for the maintenance of our hospital at RPH until our new hospital comes on board, which I've been pointed out quite a while ago that it's going to be quite a few years before we get. But so it's reassuring for patients, care, services, that money has been provided. And we've got the support of our local MP and others, you know, to push this along. And I hope that helps too. Thank you.
Just to clarify, that 35 million is over a 3-year period, and it will take that long to do that work.
And to Health Watch, what is the public and patient perspective on the proposed development, including access, transport and service provision? Thank you.
In short, I don't have much of an answer to provide. Healthwatch was originally going to be commissioned to help do some of that consultation work. Unfortunately, with the change in direction from central government, we were unable to begin that piece of work. In terms of responding to sort of Councillor Green's concerns, we've not really heard much in terms of how the hospitals are, other than a few comments about tidiness and, you know, the general condition of the hospital, which won't come as any surprise. But in terms of sort of the new hospitals, I think the general sentiment from people that we have heard of is, how do I say it, a lack of surprise that it's been pushed back. That's about as much as I know. But it's not aimed at anyone locally, it's a national picture.
Are there any other questions from members on committee? Yeah. Councillor Pritchard.
Thank you. It's been really encouraging to hear that within the strategy, the ageing population is front and centre. I wonder if there's any way that the hospital can, or the trust, is able to, when dealing with an elderly person with complex needs who's being treated across several departments, is there a way that that patient's records is kept in a centralised space, and so that any clinician is able to see, well, this person is being seen by several other departments at once? Or is it all just a case of it just happens that each department works in silo? Seems the wrong word to use, but if you get my drift, is there a way that that person is, their records are holistic, you know, that they can see exactly what's going on with that elderly person? Thank you.
Yes, there is, and it is currently in place. We have a single electronic patient record in the hospital, so people can see one specialist department can see what is going on in another specialist department. It's not in place easily across secondary and primary care and community yet, and social care, and so that's what good would look like in the future, whereby we have a single record that all partners are able to see, so that those families and patients don't need to repeat themselves and be the conduit between those services.
Councillor Michael Green.
Thanks, Jim. Just one area that we've not touched on, and that's AI. And what role is artificial intelligence playing or will play in the future for you in terms of improving patient outcomes and patient experiences?
Well, I'm certainly not going to profess to be an expert on this one. However, we are all using it. So, for example, am I okay to say the names of the different technologies? Yeah, there's no. So Copilot Professional, we use fairly routinely now to help us be more efficient about how we would summarise meetings and actions and produce information at a corporate level. That's we're becoming more AI literate. At a patient level, there's quite a lot of innovations taking place that are amazing, actually. One example is ambient voice technology, whereby you would have that running in the background in this setting, and it would capture in quite a sophisticated way the complexity of the conversations that are happening between different people and professionals, recognising the voices of the patient, the family and the healthcare professional, and then it would describe a very complex, sophisticated, multidisciplinary discussion. That is being rolled out at the moment across the hospital in all outpatient settings. So what that will mean is that the patient will get a much more comprehensive description of the discussion that they've had with the clinician, which will help understanding in future. And it will also mean the clinician doesn't then have to dictate the letter about what they've just said. I really do think that that will give us a giant step forward in helping people genuinely understand the condition, because the clinicians simply don't have the time sometimes to document and dictate. Also, the efficiencies around secretarial support and reduction that will come of that are fantastic. We are trialling some things, how that might work, for example, when somebody's having a baby, or someone in surgery, whereby the clinician that is delivering the baby or undertaking the surgery would instead just talk out loud what is happening whilst it's happening, and then the technology would then translate that into a live record. And if you can imagine, when you're trying to have your hands on delivering a baby, you can't document in a live way, you've got to document retrospectively, and so sometimes things are missed, and that can appear confusing to people. So we're looking at all types of sort of that type of technology, and then on a much larger scale, I suppose going back to the health inequality topic, you can engage with an agent, as they call it, to look at the number of people on a waiting list and tell us where the inequalities might exist and where we might focus our energy to get the best outcome for the most amount of people. And so that technology is just being developed at the moment, which will mean we'll understand in a level of detail that we've never understood, what intervention might make the biggest difference for certain parts of the population or the trust. It's really very exciting, even for a non-digital person, as I am.
Councillor Jackson.
And I can really get on board with the excitement if we're going to be using AI that way. But of course, AI, just one thing that comes to mind, AI is dependent on the information that's put in by the human. And is the bias, would there be bias? How do you eliminate bias of humans putting in that information when we're dealing with health inequalities to achieve equity?
Well, I definitely don't know the academic answer to that, but I can tell you a practical interpretation. So I think that situation I just described, like in an outpatient setting, where the patient's voice is picked up by the agent and then included in the description of the interaction, I think will remove a lot of the clinician bias that we currently see. Okay. Whereby, one person's interpretation of the experience is the documented evidence rather than the whole discussion. So I think that's going to be really positive for people, actually. Taking information out of the system that is input by the people. I'm not sure, to be honest, how you remove the bias, but it's certainly something that I'll go and ask now, Lou.
Are there any questions from members of the council not on the committee, either in the room or on Teams? Councillor Buttery.
Thank you, Chair. I don't know who to ask this question to. It's one of you, obviously. One of my residents was complaining about the car parking. Nobody's mentioned this at all tonight, car parking, and it's a very, very important question. People are waiting as long as maybe an hour and going round in a circle on Royal Preston's car park, and they're having to pay the fee at the end of that because they've gone into hospital and then come out and then they've just nowhere to park. What's the situation there?
So I would agree it is difficult, and it's something that we want to improve for people. We're currently looking at ways in which we could put additional car parking facilities on both sites. You may have seen that there's some opportunities for some park and ride at Chorley for some staff. We're trying to encourage that to happen so that we can give more car parking spaces for members of the public. We have looked at visiting times to try to look at, are they not in line with peak times for outpatients?
I think that's one of your main problems, because you've extended the visiting times. Now people have appointments in the afternoon, and they just can't get on the car park. And also you've got the disabled people who are coming onto the car park. They can't park the cars because sometimes the police cars take quite a number of the disabled bays. Perhaps that's something else you could look at.
So I've not heard that before. We'll certainly have a look at how we could influence where the police park. I think that's great feedback, thank you. And we are looking to have a solution for improved car parking within the next year. It's something that our chief exec has asked the estates team to prioritise based on this feedback, but also staff feedback as well, because it's equally quite difficult for them.
It is indeed, yeah. Well, we always say the same, don't we? Too many managers and not enough staff, not enough nurses. I hear that so many times. Is that a problem because we have too many managers?
Honestly, I don't think it is at all. The number of managers has decreased year on year in the health service. I read recently in the Health Service Journal. I find that often managers are demonised instead of being recognised for the important role that they play in coordinating operations for people, making sure that performance is where it needs to be, doing the business cases that are required to get the work done that we need. I know it is a common narrative and I understand where it comes from, but it's honestly not my experience. I work with some brilliant operational managers that make the hospital work really effectively. It'd be nice for them to be recognised a little bit more, to be honest.
And I've got a couple more questions. I had a resident who was taken into Chorley Hospital in the elderly care ward, and was moved to a temporary ward which only had 2 beds in it. There was no buzzers, there was nothing. It was literally a training room with 2 beds and a screen on the wall, the white screen. They had no proper food for 4 days. All they had was sandwiches were given to them because they hadn't filled in the form to say that they were there. I think that's absolutely appalling.
So do I, and that shouldn't happen.
One of the visitors were actually bringing in stuff from, the groceries around the corner, sort of thing. It's terrible.
So please pass on my sincere apologies for that. That's not what any of us would want for anybody, and it's certainly not the standard that I aspire to deliver at all. There are times when we have to use escalation areas, we call them, such as training rooms or other areas, because the emergency department is so busy. The capacity in the hospital has to be increased.
Well, it was a training room that came out. The nurses used to come through, and it was near an exit door.
Right.
And they used to come to get to the cafeteria.
Right.
And there was a family of rats. So there was a family of rats.
Right.
That used to, and the nurses used to come through, and they didn't shut the door.
Right.
So she had to get out of bed, pull the door to, and then you'd get these 4 rats just scratching on the door trying to get in.
Oh, right.
It must have been it was dreadful.
Gosh, I've never heard that before. So I'll take that feedback. I think I know where you.
You know what I mean?
I think I do. Certainly, we've done some focused work around removing some of the escalation spaces that were being used that are not appropriate to be used. That area is somewhere that we do recognise and use as an escalation space only when we absolutely have to, but it is reasonable to expect good quality food, the same as any other patient, and care, even though the environment isn't great.
And not stale sandwiches.
Exactly. Yeah. So it's a fair comment.
Something else that hasn't been mentioned. Sorry. I'm okay. Chair, thank you. Cancellations. That hasn't been mentioned.
Yes.
It's fine you saying that the appointments are being sent out to people now, and it might be for, say, in January they receive it for the following year.
Yes.
Not, because they can give a 12-month appointment. And then before that, you get a letter saying, sorry, consultant's on holiday, so it's cancelled for another year. And then after that year, you get another one saying you're with a different consultant, and that's for another year. So that's 3 years that they've been waiting for that appointment. And that's not good, although your figures do say, but because they have been given an appointment, they're knocked off that list because it's been given another one. Are you with me?
I am, yeah.
Yeah.
So this is a topic actually we spoke about at board a couple of months ago. Our chairman had this feedback about repeated cancellations. So we're actually doing a piece of work to look at this right now.
Thank you.
To make sure that when to understand how often those types of things occur, and to look at putting some safeguards in place so that the people don't automatically go to another year. If if their appointment is cancelled, they're given a slot within the same time frame as what they'd been on the waiting list for. So we haven't yet got an answer to improving that, but we are looking at it, and I do recognise that that does sometimes happen for people.
That'll be very interesting to see what happens.
Yeah.
Because it was me.
Oh, sorry to hear that. Sorry, could I just say though what to do if that were to happen? So in case anybody is listening, you can then contact the PALS department or the secretary for the consultant that you're scheduled to see and ask for an appointment at the same time frame that you would have had if you were on the list. And I would say this to anybody: if you're still in that situation, you don't need to say that now. You can contact me outside of here, and I will help you.
Oh, thank you. I appreciate that. Thank you. Not last one. When you said about receiving a letter from your consultant, because of the way that it works for the secretary to take it from the machine or what have you, GPs are already using the digital type of situation where you go in, you sit with your GP. She presses a thing and it just records the whole appointment.
Yeah. That's that technology.
They're doing it, yeah.
Yes, yeah.
So the hospital, they should really be doing that, shouldn't they? And it's just sent out.
Yeah. So that's being rolled out at the moment. We are.
It is doing it. They are doing it.
Yes, yeah. We've started that. It will take some time to get right through all the departments, but we're planning to have completed that before the end of the year for every outpatient area.
Good, good. And my last question you'll be glad to hear is, waiting time to leave hospital, when you've been in hospital and you're waiting to leave and you can't leave your bed until you get your prescriptions.
Yes.
That just seems silly to me because you're taking a bed for somebody that downstairs could be in real need of that bed. Anything that we can do?
Yes. So the reasons for that I explained obviously earlier. So the pharmacy team are doing some work to try to make sure that they can prescribe the medicines so the patients can go home sooner. We try to avoid sending people home without the medicines for safety reasons, because we should be counselling people. We should be giving you your medicines and then talking through how to take those, because that's important for safety, even if you've been taking them for a long time.
Right.
But really, what we need to do is make sure that we've got a mechanism to discharge people before midday. So
yes,
that is something that we are. We know
it's in our sight. The next patient.
Yeah, and we do need to do that. Some ways in which we try to make that better is we use the discharge lounge. So people would go to the discharge lounge before midday, so that they were then emptying the bed so that the beds can be accessed sooner. That helps the people that are waiting to be admitted to the hospital, but it doesn't really improve the experience for the patient that is waiting to go home. So we are cognizant that we need to do something differently about that.
I don't think Chorley have a discharge lounge the same as Preston, do they?
Yeah, there is a small area on I think it's Rookwood A that patients can go to sit in. But I think we could do that better. So I think it's fair comment. So thank you.
Okay. That's it.
Thank you
very much.
Thanks a lot.
Thank you, Chair.
No problem. Thank you, Councillor Buttery. Are there any questions from any members of the public present? Alderman Forrest.
Thank you, Chair. My question really is prompted by personal experience. Last year, unfortunately, my wife at Preston Hospital was kept on a trolley for very nearly 48 hours and was maintained by my family on a rota, basically. She wasn't fed or watered particularly. You've been very pessimistic really about the amount of capital available for extensions and all the rest of it. And I know that the government is saying, well, we'll get rid of corridor, or the target is to get rid of corridor care by the end of this government. But in the light of what you've said, do you think there's any real prospect that, frankly, within my wife's lifetime, we're going to be confident that next time she goes into hospital, that she won't be stuck on a trolley for that length of time? Because, I mean, frankly, it was very upsetting for the whole family.
I'm sure it was, and I'm sorry that that was your experience. I think that the capital topic is only part of how that will be stopped. So whilst I would like to see the emergency departments with more space, not necessarily to put more people in, I would say, just more space for the people that are in them, and the capital is required to do that, the flow through the hospital is what would really make a difference. So focusing on making sure that people who no longer need to be in hospital are out of hospital, that 100, that group of 100 patients that I've just referred to, focusing on making sure that we fix accessing care in people's homes is really critical to help in that situation, as is making sure that people can access healthcare in a different way. So we have something called a virtual ward, where a doctor would assess your wife at home if suitable, and treatment, and nurses would come out and treat her at home rather than needing to come into hospital. And they're the types of things that will really make a difference and will be the way we deliver healthcare in future, much more community based, much less hospital focused. I hope that when you come in, I hope you don't need to come in firstly, but I hope if you do need to come in, that within the next year we would see an improvement in the length of time that people are spending in the emergency department. As I said before, we have improved by about 2% for people waiting longer than 12 hours, but that's still around about 12% of people that do wait longer than 12 hours, which we recognise is too much. So I think it's multifaceted, but that is the plan. But it will rely on the development of what people are referring to as neighbourhoods now, that team around the GP practice, that those people with long-term conditions have got proper health checks every year, plans in place, what to do if somebody deteriorates, how they might manage the health at home with the support of the family in a different way. It really is a system issue for us all to tackle. Thank you.
Thank you very much for your time this evening. Darren, can you sum up, please, and put forward any recommendations?
Thank you, Chair. Some of the themes from the discussion tonight the committee might like to recommend. So the committee thanks Professor Morrison from Lancashire Teaching Hospitals Trust and Steve Wormsley and Emmy Wormsley from Health Watch for attending and answering the questions so fully. The committee welcomes the commitment to promote the call for concern feedback process and ability to report issues anonymously. The committee is pleased that the Hospital Trust and Health Watch are going to work together on the review of the patient discharge process. The committee places on record its appreciation to all employees in the health service for their work in providing healthcare to our residents. The committee encourages and wishes the Hospital Trust well in its work and plans to improve the patient experience in A&E, care on wards, integration with health and social care, reducing waiting lists and patient's voice. And finally, the committee expresses disappointment that the proposed new hospital at Cuerden has been delayed further. Thank you, Chair.
Thank you, Darren. Are councillors happy with them recommendations, or would they like to add any recommendations? No? Thank you very much. Thank you for your time this evening. Really appreciated by the committee. You're now free to go. Thank you very much.
Thank you very much. Thank you, everybody.
Thank you very much.
It's been nice to speak to you. Thank you.
Cheers. Moving on to item 6, committee matters. 6A, annual report of the Community and External Scrutiny Committee. Members are asked to agree the annual report for presentation to full council. Is everybody happy for that? Yeah, Councillor Green.
Yeah, just reading through it as a normal member of this committee, I think it's really positive and sets out some of the good work that's been done by the committee, and so well done to yourself as chairman and the members. Just nitpicking on a small item. So page 3 of that report, I think it's page 21 of the agenda. The names for the 3 councillors in the middle of the page need to be shoved up a bit because it's not clear who they are. But that's just, as I say, it's just a layout issue. Thank you.
Sure, Darren can spend some time on that. Thanks, Councillor Green.
Thanks for that feedback.
No further comments from anyone? No? Brilliant, thank you very much. Moving on to item 6B, Child Sexual Exploitation Task Group update. Matthew and Darren have been trying very hard to get the LADO to come in for a meeting, but we've not been able to get anywhere really. So we are going to be sending questions to the LADO and requesting them to send us some responses back, and that's going to be done in the next few weeks, I think. But an email is going to be sent around to members with the proposed questions so that members can add any in that they don't feel are being asked. So that's it on that one. Item 6C, Lancashire County. Sorry, Councillor Green.
It seems really disappointing that they're not engaging with the work of your task group, and that's causing delay. And I know you've met with a number of witnesses, but it's quite some time since this was agreed by full council, and you started this work. It needs to be finished. It's an important area, and it's disappointing that they're not cooperating with you.
It is disappointing. I think we struggled to get any contact from them, but then there was some contact, but then there's not been any. They've not wanted to engage in an actual meeting, have they? Unfortunately. So, unfortunately, we're left in the position where we're just going to be sending them questions to respond to, which isn't ideal, I know, but we need to get this report finalised, really. Sorry, item 6C, Lancashire County Council Health and Adult Services Scrutiny Committee. I'd like to ask Councillor Lou Jackson, the Council's representative of the committee, to provide a brief update. Sorry, thank you.
Thank you, Chair. I'm ever mindful that time's going on now, and we've been here for 2.5 hours, haven't we? And just to say that there have been 2 meetings up at LCC. One on the 22nd of April 2026. I asked the officers to circulate the minutes for that meeting to save us some time, because I know you will have read every word. I trust that you read every word, and I'll test you on it later. But just to refresh your memory, there were 2 presentations that day provided. One was on community mental health and transformation programme, an update, and one from Lancashire Constabulary, which was named Right Care, Right Person, and that was an update too. So please could I ask you to note the minutes of that meeting, please. A couple of days ago, on the 22nd, there was a scrutiny held up at County Hall again, and just picking out a few points. The meeting consisted of scrutiny work planning for 26-27. There were 2 short presentations, one named Moving the Dial and another NHS proposal timetable. This led to a question and answer session of the officers, the Adult Services, Public Health and the NHS. There was a breakout session with committee members to identify topics from both service areas and to convert into practical deliverable scrutiny work programmes for the committee and steering group for next year. The date of the next meeting will be 23rd of the 9th, 2026. I have got a short report regarding my role as a hospital governor, and I'm so glad to see Professor Sarah Morrison. She's done part of my work because we talk about the witness statements, and the last meeting was about thrombectomy. And what I'd like to just to highlight to you, because she gave us a comprehensive review of that meeting, but what pertains to us all is how to recognise the signs and symptoms of stroke. And we need to know that to help our loved ones, or if it happens to help, if it happens to us. So they talked about recognising signs and symptoms, the stroke treatment, and how there's continued stroke assessment, and how important the link to community is in the aftercare, the 90 days aftercare, post-operatively, of stroke care. It was stressed how important the golden hour is after the beginning of a stroke. So it's vital to communicate, to be able to communicate this information to everyone, to our residents, to our family, that we need to get our treatment in that first hour, and it produces such better outcomes, as the man who had actually experienced stroke in that story was able to tell us himself at that meeting. And it was great, because if we'd have missed the golden hour, he might be in bed with a left-sided, right-sided stroke, immobile. So it's so very useful, and it brings a witness story statement, it brings a meeting to life. There was a report from the executive officer. He stated that it's going to be another tough year regarding finance, and the hospitals are still not achieving full targets set. And if the targets aren't met, external forces will come in and they will start to cut. But then on better news, there have been significant improvements, he stated, on waiting times, especially around cancer care, and using the Lancashire improvement method. The 6-week standards waiting list for diagnostics, they're up to 91% of patients achieving this timescale, and last year it was considerably lower. So that's good news. There were progress in elective waits for 26 and 27, and everyone's trying to eradicate the 52 week waiting list. You were saying that productivity is up. The theatre utilisations aims to reach 85% soon, and patient follow-ups are up too. As regards cancer care, we're the 5th most improved nationally, and diagnostics that incorporate endoscopy, the number of patients receiving it are up too. At this moment in time, 5.5% of the NHS here in Lancashire and South Cumbria, the sickness is 5.5% in this area, but we're up to date with mandatory training. It was quite upsetting. He realises about how important eliminating corridor care is, and that it's vital. He said it's immoral and there should be zero tolerance of corridor care. As for AI, this as regards the patients, is centred on the patient portal, the NHS app, and developing patient engagement. This is all-encompassing in the NHS 10-year plan. And lastly, and very importantly, I joined another committee, the Patient Safety Committee that the Professor referred to. So at the meeting I thought, well, where shall I start? I thought, right, outpatients department. I went into outpatients department on tour with a senior nurse, and the nurses there wanted quite eagerly to tell me about the rise in incidents of racial abuse on nurses from patients. There should be zero tolerance, and I'll be making every effort to make this known. I started, but I'll be making it known, I'll be pressing. Because the stories that were coming out were very upsetting. The senior nurse who accompanied me, she didn't know anything about it. So I'll be working on that when I attend the NEDS meeting, which is the non-executive directors meeting, where I will be able to express my opinion, where at the directors meeting it's thoroughly an observers meeting. So it's vital that we do get on top of this, but in that instance my past experience in race in large organisations came in because I was able to give an on-the-spot action of what you can do if somebody is being racially abused in front of you. And you need to just stand by the side of that person, because at that moment they feel as though they're the only person in the world. And it's hard enough to do your job in the NHS without being humiliated, traumatised and hurt and humiliated with blatant racism. I won't tell you exactly the words that we used, but it was very distressing. Sorry to end on that note, but it's a really important note, especially in this week. It's Windrush, it's Black History Month too. So thank you very much.
Thank you very much, Councillor Jackson. Thank you for that. Moving on to agenda item 6D, meetings and training attended by Scrutiny Committee members. We held a Scrutiny training workshop last Wednesday with Darren. We've got one meeting that we need to come up with suggestions for the work programme, what we can focus on for that one. We've also discussed setting up a task group on NEAT, which is the Not in Education, Employment or Training, and we need volunteers for that, a minimum of 5 members. So if anyone's interested in that, please let us know. That'll be open to substitutes as well. So will you send an email out about that, Darren, and try and get some people in for that. Other than that, that is the end of the meeting. Thank you very much for your attendance. You're now free to go as well. Thank you.